Bismillah Rahman Rahim. In the previous lecture, we studied classification of bone tumors, and we classified primary bone tumors into different types depending on the component which tumors form. For example, bone forming tumors, cartilage forming tumors, tumors of unknown origin, histiocytic origin, fibrogenic, notochondral, vascular, lipogenic, neurogenic. So let us start with the discussion of these tumors one by one, which are more important by clinical viewpoint and university examination. So we start with the bone forming tumors. So first is benign bone forming tumors, osteoma, osteoid osteoma, and osteoblastoma. And malignant bone forming tumor is osteosarcoma, which is also called osteogenic sarcoma. So osteoma, before we go into the details of these tumors, you must know that these bone tumors, they usually occur in certain age groups. They involve certain bones, and for diagnosis of bone tumors, X-rays of the involved bone, MRI or CT scan, they are mandatory. So osteoma is a benign tumor. Middle age of the patients. So benign tumors, osteoma and osteoid osteoma, osteoblastoma. So skull, face, they are most commonly involved. Skull and face. And osteoma is famous for nocturnal pain. That pain starts at night, and they are composed of woven and lamellar bone, and differential diagnosis reactive bone. Osteoid osteoma is less than 2 centimeters in diameter, and they rise in teens and 20s. Males are affected more commonly than females. They are small in size with well-defined margins, and they are painful, as I said, but their pain is relieved by aspirin or other anti-inflammatory drugs. Pain is said to be due to prostaglandin E2 production, and there is a nidus. Morphologically, they are round to oval masses of hemorrhagic gritty tan tissue, well circumscribed, and microscopically they are composed of randomly interconnecting trabeculae of woven bone, which are rimmed by osteoblasts. Stroma consists of loose connective tissue, dilated and congestive blood vessels. and they induce a marked bony reaction. So this, you can see the image. There is central nidus and this is reactive bone formation. And this is microscopic. Interconnecting bony trabeculae of woven bone rimmed by prominent osteoblasts, and there are stromal pillaries which are dilated and congested. So osteoid osteoma. Then is osteoblastoma. So spine is more commonly affected axial skeleton. There is no bony reaction or no nidus, and pain is not relieved by aspirin. They are treated by curettage or excised and block osteoblastoma. So they are benign bone-forming tumors. Then is the malignant bone-forming tumors, and in this group, the most common tumor is osteosarcoma. Osteosarcomas, they present with mass formation, especially around the knee joint. Distal femur and proximal tibia, they are commonly affected. You can see from this diagram that 60% osteosarcomas, they occur around the knee joint. Then 15% in proximal humerus and hip joint, hip bone, then proximal humerus, and then bones of the jaw. So commonly around the knee joint, 60%. They are painful and they occur in the metaphysis. Their age presentation is late teens, early adulthood. So what are the genetic mutations? In osteosarcoma, the mutations that interfere with function of two tumor suppressor genes, that is retinoblastoma gene, which is a critical cell cycle regulator, and P53 gene, which regulates DNA repair and cell metabolism. Then abnormalities in INK4A, which encodes P16, a cell cycle regulator, and P14, which aids the functions of P53 function. These are the genetic mutations, RBG mutations, P53 mutations, P16 and P14. So then are the types of osteosarcomas. So there are various bases of typing osteosarcomas depending on the portion of the bone from which they rise, that is intramedullary, intracortical, or surface. Then degree of differentiation, multi-centricity, whether they are primary or secondary, that is primary when underlying bone is normal, not involved by any other disease, and secondary when osteosarcoma develops on pre-existing disorders like benign tumors or Paget's disease, infarction of bone, or previous irradiation. So then is histologic variants depending on the microscopic features, osteoblastic and chondroblastic, fibroblastic, telangiectatic, small cell and giant cell variants. So all are types of osteosarcomas. First is depending on anatomic portion of the bone from which they rise, In this type, we have intramedullary, intracortical or surface osteosarcomas. Then well differentiated or anaplastic, multicentricity, primary or secondary, then histologic variants, that is osteoblastic, chondroblastic, fibroblastic, telangiectatic, small cell and giant cell. So this is the X-ray of a patient showing a raised triangular lesion, lifting of the periosteum by the enlarging tumor mass, and this is a triangle. This triangle is called Codman's triangle. This is seen in osteosarcoma. So this is the gross and microscopic appearance. This is X-rays. This is the cut section of gritty gray white tumor mass punctuated by hemorrhages and areas of necrosis. So most common subtype is osteosarcoma that arises in the metaphysis of long bones. And this is primary, solitary, and intramedullary, and poorly differentiated, and produces a predominantly bony matrix. So under the microscope, there is osteoid production, mature woven bone between the cells, and then the cellular component, depending on the grade of differentiation. There are around 2 ovoid cells with pleomorphic nuclei and abnormal mitosis. So diagnostic point of identification is osteoid production by the tumor cells. These are the tumor cells which produce pink osteoid. So this is microscopy of osteosarcoma or osteogenic sarcoma. So clinical features of osteosarcoma: they are painful, progressively enlarging masses. Then on X-rays there is Codman's triangle, and they metastasize through the lungs, bones, brain, or may go anywhere. And prognosis depends on the stage of the sarcoma, osteosarcoma. So then are cartilage forming tumors, bone and cartilage forming tumors. In this group, we have again cartilage forming tumors and benign tumors and malignant tumors. Osteochondroma, Chondroma, Chondroblastoma, and Chondromyxoid fibroma, they are benign, and Chondrosarcoma is malignant. So let us discuss these tumors one by one. Osteochondroma is also called exostosis. They are common. Cartilage and bone is present. 85% of these osteochondromas, they are solitary, but sometimes they are multiple as hereditary exostosis syndrome. Males are affected more than females, and age is early adulthood more than childhood. Bones involved, they are pelvis, scapula, and ribs. So exostosis are mutations in EXT1 or EXT2 genes. It results in defective endochondral ossification. They are composed of benign hyaline cartilage covered by perichondrium, and they rise in endochondral ossification, newly made bone forming the inner portion of the head and stalk. They are often pedunculated and have a stalk. So cortex of the stalk merges with the cortex of the host bone, and rarely sarcoma may develop, chondrosarcoma. So this is the X-rays and brass and microscope. Osteochondroma. These are the islands of hyaline cartilage covered by bone. Exostosis. So this is the stalk of the chondroma, osteochondroma, and this is the mass rising from the distal end of the femur. Then is chondroma. So they are juxtacortical, and age is 20 to 40. Benign tumors of hyaline cartilage. And multiple endochondromas, they are seen in two syndromes. One is Olier's disease and other is Mahmood's syndrome. They are mostly 3 centimeter in size, grayish blue and translucent, well circumscribed nodules of benign hyaline cartilage. May undergo endochondral ossification at the periphery. Sometimes they cause pathologic fractures and rarely undergo sarcomatous transformation. So endochondroma, small bones of the joint, they are commonly affected. So this is the microscope, hyaline cartilage. Then is Chondroblastoma. It is rare. Males are affected more commonly than females. Age is teenagers. Knees and usually the pelvis and ribs are affected. Chondroblastoma. Epiphysis. Much less matrix than a chondroma. So there are compact polyhedral chondroblasts with moderate pink cytoplasm nuclei that is tabulated with longitudinal grooves. Sometimes mitotic activity and necrosis is rare. Chicken wire pattern of mineralization. They are painful. So this is chondroblastoma. So chondromyxoid fibroma, very rare. Myxoid areas with mild atypia, chondromyxoid fibroma. Metaphysis of long bones, 3 to 8 centimeters, solid circumscribed nodules of poorly formed hyaline cartilage and myxoid tissue, delineated by fibrous septa. There is localized dull pain at the affected site. Chondromyxoid fibroma. Then is malignant cartilage forming tumor, Chondrosarcoma. So they can be intramedullary or they can be juxtacortical, depending on the location of the tumor. On histology, they are conventional, again hyaline and myxoid, then clear cell variant, dedifferentiated and mesenchymal. These are the variants of Chondrosarcoma depending on the microscopic appearances. Most common is conventional. It is composed of hyaline and mixed cartilage. Then other varieties are clear cell, Chondrosarcoma, dedifferentiated, and mesenchymal. Patients are in their 40 or older, and central portions of the skeleton, that is pelvis, shoulder, and ribs, they are commonly affected. They are composed of malignant hyaline and mixed cartilage. Tumors vary in the cellularity, degree of cell atypia, and mitotic activity. They metastasize to the lungs and skeleton bones. This is chondrosarcoma. This is the X-rays. This is the grass appearance. Fleshy mass with areas of hemorrhage and necrosis. And this is the microscopy. So, pleomorphic cells, chondrocytes with multiple nuclei, extreme pleomorphism. And this is hyaline and mixed cartilage. Hyaline. This is hyaline variant, and this is mixed. And this is clear cell. So that is about the cartilage forming tumors.